Thank you very much for coming today, Saturday. I just want to introduce myself. My name's Carsten Palme. I'm a head and neck surgeon at Chris O'Brien Lifehouse. I'm an ENT surgeon by trade. I've done head and neck oncology fellowships in Canada and Europe. I started my career in 2002 at Westmead, and now I've been at RPA and Lifehouse since 2012. It gives me great pleasure to introduce Professor Mark Shifter, and Mark and I have had the pleasure of each other's company for, over 20 years now, Mark. so this has been a long relationship, and Mark and I have been very keen on promoting oral health, and particularly recognition and management of oral cavity cancer. So today Mark's going to talk to you a little bit about white lesions, pre-malignant lesions, a little bit about oral cavity cancer, and then I'm going to talk a little bit about what's involved in managing those patients. But I thought initially I'd give you a bit of a flavour what is Chris O'Brien Lifehouse. It's a completely new entity really in New South Wales Health. It's a hospital that was really born out of the vision of Chris O'Brien, who was a well-known head and neck surgeon who unfortunately died in 2009 from a malignant brain tumour. And it was really his vision as a head and neck surgeon to develop an all-purpose one-stop shop comprehensive cancer centre akin to some of the major institutions around the world like Memorial Sloan Kettering, MSK in New York. And really it was through Chris's work and dealings with governments that this really came to fruition. So Lifehouse is a private institution. It has a private executive, but it is a not-for-profit public-private partnership, and it works incredibly closely with Royal Prince Alfred and the Sydney Local Health District. It's on the campus of Royal Prince Alfred, and it derives actually the majority of the oncology budget, which used to go to RPA for public patients, has come to Lifehouse. So Lifehouse is an institution that not only treats private patients, but importantly treats public patients. And it's probably really the only kind of institution of its kind, certainly in New South Wales, if not Australia. And it is my strong belief it's really the only hospital that can really deliver this kind of equity, equity in care across a number of oncologic services. It's vertically integrated. By that we mean the clinical activity occurs together with research and together with education. There are a number of tumour streams. Head and neck has the largest footprint, but we do have gynecological oncology, breast cancer, colorectal, upper GI, neurosurgery, and thoracics. Chris's vision always was that, in order to achieve excellence, the patient has to be front and centre of this comprehensive system, which really tries to deliver holistic, compassionate, and evidence-based care. It's really important that patients are empowered with knowledge to participate in their own decision-making. And through Chris's own journey, his tragic journey, he really recognised that not only is it the surgery, the chemotherapy, or the radiation, but there are other important adjuncts to treating patients in terms of acupuncture, massage therapy, and placing value in psychological support. Head and neck is a complex area, and it really requires a team of doctors. It's not just myself or Mark, but we really are only a small part of a much larger team. We at Lifehouse have 10 head and neck surgeons who come from ENT, general, and plastics and oromaxillofacial. We also have many radiation oncologists and medical oncologists. We have the largest fellowship program in Australia. We have annually 4 clinical fellows that join our unit from all around the world. So we have had people from all over Europe, Asia, and North America. And currently we also have Dr. Kevin Nguyen, my fellow here from Melbourne, training with us. We have many registrars and medical students, and until COVID, there were a lot of overseas visitors to our unit. We must not forget our allied staff, our nurses, speech therapists, and dietitians. And importantly, Lifehouse, and this really was one of Chris's big issues, is to have a place where patients can escape their clinicians. You know, it's called the living room. It's an area downstairs where patients and their families can kind of, you know, have downtime and relax. And in that environment, there is acupuncture on offer, massage therapy, etc. So this is quite a unique kind of wellness centre within Lifehouse. In terms of head and neck, and you guys being dentists are clearly at the forefront, and I'm not trying to tell you how to suck eggs, so to speak, but you know, head and neck is about 9 to 10 different types of conditions that really extend from the base of skull to the thoracic inlet to in front of the spine, and it covers really the entire upper air digestive tract, you know, oral cavity, throat, nose, sinuses, thyroid, parotid, other salivary glands, and importantly, massive skin cancers that we all see, you know, particularly here in the regions. We all know, you know, what the causative factors are. However, you know, human papillomavirus has been a massive etiologic agent in terms of driving tonsil and base of tongue cancer, and we've probably seen an increase of about 200% over the last 10 to 20 years. Clearly, the sun plays a massive role, and we don't need to talk about smoking and alcohol. Treatment is usually multimodality, including surgery and non-surgical techniques, but we also must not forget rehabilitation, and that's certainly something that I'll talk a little bit about, particularly pertaining to the oral cavity and the state-of-the-art work that we have been doing. We also must participate in trials, and I've been a director of Head and Neck Cancer Australia, which is an information website for patients and carers, really the only of its kind in Australia. In order to excel, I think we all need to strive towards the really 3 fundamental pillars of clinical research and education. You won't be a centre of excellence unless you meet all those 3 criteria, and I think that's really important. So we practice within a multidisciplinary team, and we have by far the highest volume of complex cancer surgery in this state, if not Australia. We have a very large teaching program and research program. We have over 3 NHMRC grants. We have many PhD students, and we probably publish somewhere between 30 to 40 papers annually. And all this put together leads to great outcomes, which improve survival and importantly is cost effective for our politicians. So in terms of complex volume, the Cancer Institute brings out numbers each year. And this is really just to show you, just to give you a flavour of what head and neck surgery is like in New South Wales. So complex cases are cases that will require resection of a mouth cancer, free flap reconstruction, and neck dissection. And the Cancer Institute has said that 25 cases per year should be performed by an institution to main standard. I think that's way too low, and the real number is probably closer to 50 to 60. Nevertheless, that's the number that they put down. There are 67 institutions in Australia, in New South Wales alone, who have performed complex head and neck surgery, of which only 11 meet those 25 annual criteria. The busiest public hospitals perform around about 70 to 80 cases a year, but you can see that Chris O'Brien Lifehouse performs by far the most common cases out of all those centres. And that really leads to much greater outcomes in terms of survival, length of stay in hospital. So I think the tumour volume and outcome curve, although not perfect, really shows a great trend. The more things you do, the better you get at it, and the more streamlined the treatment will be. So my vision, or our vision, has really been to spread that expertise in a hub and spoke model, not just to metropolitan patients, but also go to the regions. We participate with our national colleagues on research, and also through our training programs, take international fellows and perform research on an international basis. 3 years ago, I started I came up with the concept of outreach clinics. So I started a clinic in Port Macquarie about 3 years ago, which really functions in a sense that the expert goes to the region and becomes a landing spot for patients with complex head and neck problems. So they don't need to travel from all around that area to Sydney for a 10-minute consult or the biopsies wherever they get done, then go back and forth. They travel once to our clinic. The patient is assessed locally, worked up locally with imaging and biopsy. A plan is created, and importantly, we work very closely with the local healthcare infrastructure to deliver the best care for that patient. And that patient's management and advice links straight back to our multidisciplinary team, and that's how we can provide state-of-the-art treatment for those patients. One of my colleagues is now doing clinics in Tamworth for the last year. We have one of my colleagues in Nowra for many years. One of my plastic surgical head and neck doctors is doing skin cancer clinic here in Orange. And the next clinics are planned for Dubbo and Camden. Why bother with regional clinics? I think the answer is intuitive, because it buys into well-established centres that can deliver excellence in care. It doesn't work for all cancers. It works very well for uncommon and rare tumours. For common tumours, we generally like to move the specialist to the cancer. But for rare cancers, we generally want to move the patients to the resource. Now, given our geographic challenges in Australia, I think a hybrid model of having a specialist move to the regions and become a focal point working together with the local healthcare infrastructure, I think works best for those kind of tumours. All those patients can access that state-of-the-art, a high-volume quality care that we've talked about. It only works if we work with you, other local healthcare professionals, and importantly, the local cancer centres. I think it provides much better, consistent, streamlined and equitable care. We can participate in research and quality assurance, and importantly, we can provide education not just to the patients, but your primary caregivers, other specialists, and the community at large. I think without doubt it reduces travel, it reduces cost, it reduces time away from work, it improves quality of life, it gets people off the roads. It is cost effective. Importantly, I believe it assists in building regional infrastructure and growth. For regions to succeed, and I am talking to a region that is incredibly successful, so I'm not so much talking to you guys, but you need to have jobs, you need to have education, and you need to have healthcare. I mean, these are the three fundamental pillars. If you don't have any of those, the population just can't be confident, and that's why people tend to move to the cities. But if we improve the healthcare delivery and we show people that they can access the same standard as their cousins in Sydney, that is only going to buy into the sustainability and growth of the regions. So I think having regional clinics is a lay down misere. It improves patient outcomes. We do this with zero support from New South Wales Health, because the problem is, when we talk to Royal Prince Alfred, Westmead, other public hospitals, there is just no interest because it's not their LHD's responsibility. If you go to Ramsay, they say, what money is that going to bring? They're just not going to be interested. So Lifehouse has been in that fortunate position where our executive and our vision has allowed us to build on the ultimate vision of Chris O'Brien. And we have gone to philanthropy, and we've been very lucky that we've had some donations. And of recent, I've been incredibly fortunate to hire a dedicated regional care coordinator in Tanya Dawson here, who's really starting to coordinate all the regional care. So I think the success of Lifehouse is that we do deliver compassionate, personalised, prompt care and empower patients with knowledge so they can be part of the decision-making process. I think this public-private partnership, which is often looked upon negatively, works in our setting and delivers equity in care. This vertically integrated service and the concentration of highly trained and internationally renowned clinicians delivering multidisciplinary care in a collegiate and respectful environment, in my opinion, drives the outcome that we've seen so far. And although we've only been open for the last 6 years, I do see that the future is very bright in terms of improving care to our head and neck community. So this is really just to give you a little bit of a flavour about Lifehouse. So I'm now going to invite Professor Mark Shifter to the podium. Thank you.